Hello, this is Jeff Mazzell. I've already provided some lectures on psychopathology covering chapters 14 in your textbook. Today I'm going to be covering chapter 15, which deals specifically with the treatment of psychological disorders. Let's start by asking the question, who seeks treatment? And I want to provide you with some general points to help anchor your understanding of the answer to this question. So approximately 15% of the population in the United States seeks some form of mental health treatment each year. So that's a significant number, but one of the things that we know for sure is that this is a gross underestimation of the number of people both who need, would benefit from psychological treatment, but also who could use treatment at any given point in time. We also know that more women than men seek treatment, and we could ask the question, why might that be? Typically, those with medical insurance are the ones who avail themselves of psychotherapy at any moment in time. But we also know that a lot of people without insurance are getting psychological treatment, often through emergency medicine services. Those with higher levels of education are also more likely to seek mental health services. And in terms of disorders, depression and anxiety are the most commonly treating disorders in the United States. So this gives you a little bit of an overview of who seeks treatment for mental health problems. Let's take a slightly more fine-grained look at that. So as you see from this graph here, what I've done is provided data that breaks down basically what I've just reviewed, looking at issues like medical insurance, marital status, divorced, separated, married, single, for instance, levels of education, age, and gender. And this gives you a bit of a picture of the data that went into some of the points that I just made. So take a second and look at this and see what comes to mind for you. Now, turning to our next slide, what you see here graphed is the proportion of people who are seeking and obtaining treatment based on the type of psychological disorder that they might have. And here again, take a look at this one. One of the things you'll see is that perhaps major depression and anxiety are the most commonly treated disorders, certainly of the DSM disorders, but you see that a lot of the other disorders are being treated at about the same rate. Now, who provides treatment? Who provides mental health treatment to the kinds of demographics that you've just seen on the previous slides, or based on the kind of psychological disorder that somebody might be struggling with? In the United States, and I think this is fairly typical in most modern industrialized first world countries around the world, clinical psychologists or psychiatrists are the two leading providers of mental health services. Clinical psychologists include people with PhDs, which are research degrees, or PsyDs, which are more treatment-focused degrees. Counseling psychologists also with PhDs or with masters are common providers of mental health services. But then I think psychiatry is likely to be the one of the two larger professional degrees that provides mental health treatment. And again, the major distinction between psychiatry, individuals with an MD, and psychologists and counseling psychologists with PhDs is that MDs have been trained to provide medication, whereas psychologists are generally providing talking therapies and other kinds of cognitive and behavioral therapies that I'll be reviewing in a bit. Additionally, we have clinical social workers, which is a large and very common class of professionals who are providing treatment. Clinical social workers, often with master's degrees, are not involved in providing medications, but part of their training is to be very alert to or aware of somebody who might benefit from medication and to provide referrals to psychiatrists. We have psychiatric nurses working in tandem with psychiatry or clinical psychology, and often those are individuals who are working in hospital settings or inpatient mental health treatment settings. They work in combination with psychologists and psychiatrists. And then finally, a large class of, or a catch-all class would be referred to as paraprofessionals. And these are individuals with not necessarily additional formal educational training in the provision of mental health treatment, but who probably by experience and based on their own professions have acquired a good understanding of how to help other individuals. And often we find that different sociocultural or cultural and ethnic groups will favor paraprofessionals. For instance, priests and faith workers, teachers, educators are often in this role. So you can think of a whole class of individuals who, while not trained in mental health treatment provision, by virtue of who they are and what their profession is, are often working closely with individuals who are struggling with mental health treatment problems. Okay, now let's focus now on the basic approaches to the treatment of psychological disorders. And organizing this section, I want to ask the question, how do we treat psychological disorders? So we've talked a little bit already about who seeks treatment and who provides treatment. Now let's actually dig in and look at the types of psychological disorders that we've reviewed in Chapter 14 and ask the question of how do we actually treat these. I think the easiest way to approach this question is to organize the basic psychological treatments into two major classes, those that are biologically based and those that are really focusing on psychological processes. And I'll start with biologically based interventions. And as you probably can appreciate, these approaches to treating mental illness reflect medical ideas of what constitutes psychopathology or what constitutes mental disorders and diseases. The other major class would be psychologically based interventions, or what we call psychotherapies. And these are, although they may have a belief that the kind of disorder you're treating is biologically rooted or is affected by your biology, the major goals or aims of psychotherapy is to change patterns of thought and behavior through other kinds of psychological mechanisms, not addressing underlying biology, but addressing cognitive processes, emotional processes, and behavioral processes. So these are the two large classes of treatments for psychological disorders. Let's now take a look at these a little bit more carefully. Now, a lot of you probably have either first-hand or second-hand experience with biological approaches to treating mental health issues. This is perhaps one of the most common, if not the most common approach. It's often thought to be the frontline approach for dealing with mental health problems. And it takes the form of what we call pharmacotherapy, or the prescription of medication. So psychotropic medications, or medications that are prescribed for psychological problems, are a class of, or different classes of drugs that really are geared at changing brain neurochemistry and in the process affecting mental processes and even behavioral processes. There are many different kinds of pharmacotherapy or medications used to treat different kinds of disorders, and they all operate in the brain differently. For instance, a number of them would be geared or developed to inhibit the way certain kinds of areas of the brain are functioning, inhibit neurochemistry, inhibit neurofiring. Others are designed to increase or even decrease the activation of different kinds of neurotransmitters. So if you remember back to our chapters on the brain and how brain chemistry is really what drives psychological processes, you can think about medications that have been developed to target neurotransmission, either by increasing or decreasing the availability of a range of different kinds of neurotransmitters. So psychotropic medications are really operating in different ways, but have some of the same outcomes in mind: changing thought processes, emotional processes, and ultimately behavior by regulating neurochemistry. When we look at the kinds of or classes of pharmacotherapy that's available right now, we see largely three types of drug categories. Modern day drugs targeting major psychological disorders fall into categories such as anti-anxiety psychotropic medications, antidepressants, and antipsychotic medicines. Now, these three classes are operating, and sometimes similarly, but at the core they're really targeting different areas of the brain, and their usage reflects different understanding of what might be causing psychopathology for somebody. All right, so let's look at anti-anxiety drugs. So in general, these are medications that have a tranquilizing effect, and commonly these are referred to as tranquilizers. So a drug such as Xanax, which is commonly used term in popular media, etc., is a drug that's targeting areas of the brain that lead to elevated mood, increased nervousness and arousal, and by tranquilizing or calming these circuits in the brain, we generally think that we can lower symptoms of anxiety. Benzodiazepines, which is the formal medical name for these kinds of anti-anxiety medications, for instance, Xanax, have as their action increasing the activity of certain kinds of neurotransmitters, something like GABA, which is a neurotransmitter in the brain that's involved in regulating mood and arousal. And by increasing neurotransmission of something like GABA and other neurotransmitters, what we believe and what this drug reflects is the theory that anxiety is a deficit of a neurotransmitter like GABA. The absence of sufficient GABA in the brain increases arousal, increases nervousness, increases feelings and states of anxiety, and by bringing these levels to what we would consider to be normal, typical levels, the theory is that benzodiazepines such as Xanax, by increasing GABA, would lower symptoms of anxiety. Now, as you're going to see or hear in the next couple of minutes, and hopefully you've read in Chapter 15, any kind of medication that we might prescribe to deal with treat mental health problems are going to have positives, but importantly are often carry side effects, or what we call cons and negatives. And in the use and prescription of any kind of drug, we need to think carefully about both of these. So the pros for anti-anxiety medications, as we would hope, is that it reduces anxiety and through tranquilization processes promotes relaxation. But the cons, especially if you don't have the right dosage level or may have prescribed anti-anxiety disorder that doesn't really work well with a particular person's neurochemistry, can lead to things like, heavy sedation, drowsiness, and there's been shown through research one of the biggest cons of anti-anxiety medications is the likelihood of forming an addiction to these kinds of medications. So, as you've probably seen in media and films, etc., tranquilizers are highly addictive, and this is one of the serious cons. All right, now looking at antidepressants, as the term suggests, these are used primarily to treat depression, but because, as you know, theoretically and conceptually, depression and anxiety share a lot of common features and implicate similar brain areas. Antidepressants are often used to treat anxiety as well. There's two primary antidepressants that are used to treat depression, or what I mean, there's two classes of drugs that operate in different areas of the brain with the goal of treating depression. The first of these are what we call MAO inhibitors, or monoamine oxidase inhibitors. And what these medications do is they inhibit symptoms of depression by working in the synapse of the brain to make more serotonin or neurotransmitters like serotonin available to the brain. One of the things that MAOs do is they also raise levels of norepinephrine and dopamine, and these are, in addition to serotonin, two other kinds of neurotransmitters that have been implicated in depression. Now, one of the things that we know about MAOs is that they have a fairly significant side effect profile, and so they're used much more cautiously than SSRIs, which I'll talk about in a second. So these are generally types of drugs. MAO medications are often used only for those individuals who aren't responding to other kinds of antidepressants. So again, MAOs work to break down serotonin in the synapse and ideally raising the availability of certain kinds of neurotransmitters. Now, selective serotonin inhibitors, or what are called SSRIs, are perhaps the most commonly used antidepressants today, and these include medications that are generically known as Zoloft, Prozac, etc. And what these class of drugs do is, rather than breaking down and altering the way MAOs do the supply of serotonin, norepinephrine, dopamine, they work to alter or adjust the rate at which the brain utilizes serotonin. And one of the things that serotonin inhibitors do is that it targets what we call the postsynaptic neuron and makes it less receptive to serotonin, which essentially means that there's more serotonin circulating in the brain. And what we believe is that it's a deficit of serotonin in the brain that is related to depression. So these kinds of SSRIs, whether it's Zoloft or Prozac, operate in somewhat different ways, but the net effect of these is that they're allowing the brain to have more circulating serotonin, which we believe is critical to lowering symptoms of depression. All right, now turning to antipsychotics, the third class of pharmacotherapies. Antipsychotics, as you probably can appreciate, are used to treat mental health disorders that have psychotic symptoms to a more psychotic features, and perhaps most commonly this would be a disorder like schizophrenia. Anytime somebody is dealing with a major mental disorder that might not be schizophrenia but carries with it some kind of psychotic feature, for instance, bipolar disorder, when somebody's in the manic phase of their cycling, we might use an antipsychotic to treat this. Somebody who is deeply clinically depressed and has strong agitated features might sometimes present with psychotic symptoms. We might use antipsychotics. So it's not just limited to schizophrenia, but this is the number one class of drug to treat a disorder like schizophrenia. Now, you remember back to your reading and the presentation about, say, schizophrenia and what the types of symptoms are, positive and negative symptoms. Antipsychotic medications are generally treating the positive symptoms. So they're targeting the reduction of hallucinations and delusions. So these are the positive symptoms of schizophrenia, and antipsychotics are attempting to lower the likelihood that somebody's going to be experiencing hallucinations, lowering the likelihood that somebody's going to experience delusions. And the way that antipsychotics generally work is by targeting the dopamine system and by blocking the effects of dopamine. So one of the things we know is that it's a surplus of dopamine, or the way in which dopamine is acting on vulnerable circuits in the brain that seems to be driving hallucinations and delusions. So antipsychotic medications are generally trying to block the effects of dopamine. One of the things about antipsychotics that is very important to understand is that they are either not effective in many cases, although they're still our frontline way of treating active psychosis, but they also have a number of potentially irreversible side effects. Individuals who are on antipsychotic medications for a long time might develop side effects such as tardive dyskinesia, which is a form of a mental tremor, a neurological tremor that expresses itself both behaviorally in the forms of tremoring limbs, or sometimes it expresses itself in terms of stuttering speech. So these are really significant side effects. Now, the other thing about antipsychotics is that while they might be effective in treating the positive symptoms, they themselves are not very effective at treating the negative symptoms, things like social withdrawal, apathy, depressed mood. And often what psychiatry will do is use combinations of medications, such as antipsychotics and antidepressants, to treat both the positive and the negative symptoms. Because combinations of drugs increase or double the likelihood of side effects, developers of medications have been trying to target combination drugs that in one will address both positive and negative symptoms. So neuroantipsychotic medications such as clozapine act on the dopamine system, but also have properties that act on other neurotransmitters in the brain, such as serotonin and norepinephrine. So these newer classes of antipsychotics are showing to be more effective at treating the areas of the brain that seem to be involved in schizophrenia. But because it's a newer class of drug and we still don't have as extensive research as we would need, oftentimes these newer drugs are used only for those who aren't responding to other better studied antipsychotics. So this slide shows you what we call the psychotropic mechanisms of action, and this is a schematic, if you will, that is not specific to any one of the medications, the psychotropic medications that I've just described, but is a review of the way in which different kinds of psychotropic drugs can alter behavior by interacting with the brain's neurotransmission system. So again, depending on the class of drug and what neurotransmission system it's targeting, these drugs may operate to release or increase the release of certain kinds of transmitters into that synaptic region, a synaptic cleft, which is where a lot of the action in the brain happens, or it may be targeting the receiving neuron and block the reuptake. So it's dampening the utility of neurotransmissions, and etc. You see some other ideas here. So what I encourage you to do is be refamiliarized with the way in which these kinds of drugs might be operating in the neurons in the brain, and this is exactly when we treat different kinds of psychopathologies, what we're trying to do when we use medications. Okay, now drugs are not the only biological treatment options that psychiatry and clinical psychology has at its disposal. We also have potentially some more drastic approaches, and in some instances these may be the only options we have when people haven't responded to different kinds of drugs. So surgery is still a biological option. It's often, though, the court of last resort when it comes to treating serious mental disturbances. So things like lobotomies that have been, demonized and popularized in different kinds of media is a form of psychosurgery that would be used when somebody hasn't been responsive to any of the other kinds of drug or talking therapies. Also, historically, ECT, or what's called electroconvulsive therapy, has been a commonly used biological approach to treatment, and it's often used, for instance, in treating cases of depression that are highly unresponsive to, or essentially non-responsive to any other kinds of biological interventions. And essentially, ECT as the name of it, electroconvulsive therapy suggests, is an administration of an electrical current into the brain and essentially causing micro seizures in areas that we think are probably not functioning optimally, and it really is designed to try and reset homeostatic levels of different neurotransmitters. So by creating these micro seizures in areas of the brain that are, we believe, functioning inappropriately, the seizure essentially serves to reset these homeostatic balances and gives the brain a chance to start functioning the way it would normally do. Now, again, it's used to treat very severe cases of, for instance, depression, and like any of these other medications that I've reviewed, would carry certain side effects. However, for individuals who have been completely unresponsive, some of the research suggests that this is perhaps one of the most effective ways of improving the likelihood that somebody might be responsive to a medicine and a talking therapy going forward. Some additional alternative biological treatments also include what we call TMS, or transcranial magnetic stimulation. Now, this is a little less drastic of approach compared to ECT, but it works on the same principle that by introducing mild electrical currents into the brain, we might be able to induce alterations in neural circuits that might be malfunctioning. The way TMS, or transcranial magnetic stimulation, works is that it interrupts neural functioning in really targeted regions, and it's this disruption that might alter certain symptoms. Again, like ECT, it's often used to treat severe vegetative and non-responsive depression. Another much newer biological approach is what's called DBS, or deep brain stimulation, and this is a combination of both surgical implantation of electrical diodes, if you will, into the brain, and this concept of introducing electrical currents. And essentially what happens is that we surgically implant these electrodes into the brain and into areas of the brain that we know to be involved in certain kinds of mental health and neurological disorders, and that this slow and steady introduction of electrical current into the brain stimulates normal functioning in these areas that might be deficient. And a nice analogy of this is that a deep brain stimulator is very similar to a pacemaker, which essentially operates to help the heart continue to function normally. Deep brain stimulation has been used in a variety of different kinds of psychopathologies. For instance, it might be very effective in treating depression that hasn't responded to medications and some certain other approaches. It's also been shown to be effective in treating OCD or obsessive compulsive disorder. But increasingly it's being used later in life for neurological and degenerative disorders like Parkinson's. And one of the things we found is that it has both fewer side effects than some of the heavy-duty drugs that are used to treat Parkinson's, and also has some unintended effects that, for instance, it reduces some of the tremoring problems that comes with Parkinson's, in addition to trying to affect some of the memory and cognitive functions that are features of Parkinson's. So these would be the host of alternative biological approaches that would be used today, probably mostly by psychiatry, that is, again, very much rooted in the biomedical model of psychopathology. All right, let's turn now away from the biomedical model and turn more towards the psychological model or approach to treating mental health problems, and that would be a class of treatments that are called psychotherapy. These are, let's call them for now the talking therapies. So as an overview, let me just say that there's been a lot of research done both on biomedical interventions into treating psychopathology, but also a great deal of research that's looked at the effectiveness of psychotherapies, talking therapies. And one of the things we know now, after well over about 100 years of research on different types of psychotherapies, is that some of them have been shown to be effective and some of those have been shown to be less effective. And so what you have here in this graph or this table is examples of psychotherapies that either are very difficult to study through research or when studied have shown limited effectiveness versus those that continue through repeated analysis and investigation have shown themselves to be our most effective talking therapies. So, historically, Freudian types approaches to treating psychopathology in the form of psychodynamic therapies or other kinds of approaches such as hypnosis or more commonly crystal therapies, which are popular in certain parts of the country. The research that has been done on these types of approaches to dealing with mental health problems have shown that they have limited or no positive benefit. So while they may still be popular, the scientific literature doesn't provide a great deal of evidence that they're effective. In contrast, we have both a lot of research evidence as well as research evidence that suggests that a variety of other kinds of therapies are effective, and these would include things like cognitive therapies, or more commonly cognitive behavioral therapies, CBT, and some newer examples of psychotherapies that would include things like dialectical behavior therapy, DBT, ACT, acceptance and commitment therapy, and mindfulness-based cognitive therapies. These would be considered the set of psychotherapies that have the strongest research evidence behind them, and consequently these are the ones that are most used to treat different kinds of psychopathologies. And what I want to do for the next few minutes is talk about those with a strong research support. All right, let's start and look at cognitive therapy. Cognitive therapies have evolved primarily to treat depression. Again, if you remember back to that first graph and what you know about psychopathologies, depression is one of the most prevalent disorders, and consequently a lot of the treatments that have been developed and tested are geared to treating depression. And the major theory behind cognitive therapy reflects the major theory of what depression is, and that is that depression results from distorted thoughts. And so the theory of cognitive therapy is that through the treatment of distorted thoughts that produce maladaptive behaviors and emotions, we can alter depressive symptoms. So the goal is to identify those problematic cognitive or thought patterns and to modify them through a variety of different types of interventions, and to change problematic and negative thought patterns to more adaptive and positive thought processes. And this is within cognitive therapy what's called cognitive restructuring. In terms of the length of this kind of therapy, it's probably a typical length therapy lasting anywhere from 10 to 20 sessions, sometimes longer, sometimes less. But, typically and on average, it's somewhere in that 10 to 20 session range. So you can accomplish a fair amount in a reasonable amount of time. So just to give you an example of how cognitive therapy might work, somebody's depression might be defined by maladaptive cognitive patterns that really suggest somebody is very hypersensitive to feedback, and the response is that they're constantly getting negative critical feedback, even if somebody might not be intending to be negative. But in this example that I have here, imagine somebody's boss or a parent is critical with them, and the distorted thought process is that negative feedback that they're getting really translates into self-esteem issues, feelings of worthlessness, and it's that feeling of worthlessness that translates into or can contribute to the onset of depressive symptoms. So cognitive therapy's goal would be to cognitively restructure the meaning of what it is to have somebody become cross or provide negative feedback. So when a boss or a parent yells or becomes negative with somebody, the goal of cognitive therapy would be to say, this isn't about me. This is probably something about this person. So this person might be having a bad day, and to not internalize it and make it something about oneself. And the thought is that by altering these distorted cognitive thoughts, that this is going to make it less likely that somebody is struggling with symptoms of depression. All right, now let's look at cognitive behavioral therapy. And this is clearly an extension of cognitive therapy, and research on cognitive therapy has shown that while it can be effective in treating disorders like depression and other disorders like anxiety, the lack of focus on some of the behavioral aspects of disorders like depression and anxiety has made a lot of clinicians feel that a treatment approach such as cognitive behavioral therapy is more effective. Again, cognitive behavioral therapy has been used to treat a variety of disorders, but in general, when you look at the research literature and you look at the way in which different professionals use it, it's primarily used to treat depression and anxiety. And at the core, the theory of CBT, cognitive behavioral therapy, is that, again, we have distorted or maladaptive thoughts and consequently feelings, and that these distorted thoughts and feelings play a critical role in shaping the kind of behavior that becomes problematic for somebody. So the goal of cognitive behavioral therapy, like cognitive therapy, is to first identify and to change those distortive, destructive, or disturbing thought patterns, and to try and ensure that they do not negatively influence feelings and behavior. And so it's when it's working well for somebody, it's a combination of a focus on both the thoughts and feelings, but also behaviors. And I'll try and make that clear. Like cognitive therapy, CBT, cognitive behavioral therapy, we think of generally as a short-lasting therapy, somewhere in the neighborhood of 10 to 20 sessions, 10 to 18 sessions. So again, a lot can be accomplished in a very structured or manualized approach to dealing with thoughts and behaviors. So let's look at an example here of how CBT might work with social phobia. So again, CBT is focusing on thoughts, emotions, and behavior. And what you might see from this slide here is that somebody's distorted thoughts might include things like the fear that people are judging you, or that that one is worthless because they can't function in social situations. And so the ultimate result of those feelings is, because they engender negative emotions such as nervousness and sadness, that those thoughts and those feelings are going to lead to behaviors such as avoiding or escaping or leaving social situations, which is essentially going to produce this self-fulfilling prophecy, which creates this negative spiral of events. So once you begin to engage in less social activities or escape and avoid social situations, that's going to increase the feeling that you're worthless, socially inept, which increases negative and sad emotions. So this cognitive spiral would be the target of CBT. So how would CBT address something like social phobia? So what are the tools available? So again, the first target would be cognitive restructuring and trying to address those inaccurate thoughts about one's worthlessness, or the idea that everybody is looking at you and judging you. The next major goal or tool within the CBT toolbox would be to deal with the emotions that those distorted thought processes create. So putting people in situations where they actually see that they can manage the emotions that those distorted thought processes might create. And then finally, by using certain kinds of behavioral strategies that create more pleasurable or positive experiences. So I've provided you a link here to a really good example of what's called exposure therapy for social anxiety, or in this case, it's a phobia. And it would work similarly for social anxiety and other kinds of anxieties about certain situations. And what you see from the example is that the goal is to address both the distorted thoughts, the emotions that get created in certain situations by those distorted thoughts, and to create new actions and new action goals that would address the core symptoms of something like a phobia. And this is a really nice example, video example of how we would use exposure therapy to deal with a particular kind of anxiety disorder. And these are all examples of how cognitive behavioral therapies, by focusing on thoughts, emotions, and behavior, might reduce something like phobia. Could be used similarly for addressing depression. All right, let's move beyond cognitive and cognitive behavioral therapies and look at newer classes of psychotherapies. Perhaps one of the newest, but also one of the most popular and psychotherapies getting a lot of attention, both professionally and by the scientific community, is a therapy called ACT, or acceptance and commitment therapy. A lot of people believe that this is the new wave and a very promising future for the treatment of psychopathologies, and we're probably going to see in the next 5 to 20 years therapies like CBT incorporating aspects of ACT, because it's really showing itself to be very effective. ACT is very effective in treating a wide variety of conditions. So whereas we're finding that CBT, cognitive behavioral therapy, is really effective at treating depression and anxiety, acceptance commitment therapy is used to treat depression and anxiety, but it's also being used in the treatment of a whole variety of other kinds of disorders, including substance abuse problems, etc. So what is ACT? Theoretically, the idea behind ACT is that individuals are suffering psychologically, and that this suffering increases because we're trying to control what is bothering us. And it's this struggle to control the symptoms and the negative emotions that get generated by problems that lead to different kinds of clinical psychopathologies. And essentially at the core of ACT is this idea that psychological suffering is really a normal part of the human condition. That, at different points in our lives, we're going to experience psychological disturbance. We're going to experience symptoms of depression. We're going to experience symptoms of anxiety. That this is really, an inevitable aspect of being a human being, operating in a complex world. And what ACT is trying to do is to normalize that, to lower the need to fight and resist it, and to increase the way in which we can think about those things as a normal part of living, and hopefully those don't cause us the same levels of distress and disturbance that they might when we're resisting them and seeing them as abnormal and distorted. So the goals of ACT are really threefold. One is what we call acceptance, as the name of the treatment suggests. And by increasing acceptance, we're emphasizing or supporting an individual's willingness to tolerate unwanted thoughts and feelings and experiences. So in other words, to create the space in your life for them, make room for them, and to see them as a natural part of the human experience. One of the ways in which that acceptance can be achieved is by being very present focused and encouraging individuals to really not be trying to escape these feelings by retreating to the past, glorifying the past. I was really great then and healthy then, and or to look to the future, but really to try and emphasize the importance of being present in the here and now, to being conscious of what's going on. And as I'll talk about in a minute, this is an exercise that is now being thought of as are called mindfulness, and being mindful about where you are and really living in the here and now has been shown to be highly effective in reducing things like depression and anxiety. And the third piece of ACT, or acceptance and commitment therapy, is what we call value-focused interventions. And this is where we're encouraging individuals to set goals that reflect what you want for yourself, what you value in your life, and to take positive steps towards achieving those goals. Not to be critical when you fall short of those goals, but again, to have a sense of goals and value-focused objectives, and through acceptance processes and being present, to slowly work to achieve those goals. These would be the positive behavioral aspects of one's life that lower the feeling that life is a struggle, life is difficult, and by achieving these goals that are in line with your values, ACT believes that this will help to reduce some of the core symptoms of psychopathologies like depression, anxiety, reduce the need to use substances to manage some of the suffering that goes along with being a human being. Now, I said when I was talking a second ago about ACT that one of the core tools is mindfulness. And there's been a lot of research in the last 10 to 15 years, or even more recently than that, really focusing on that very specific aspect of ACT, because it's not limited to just acceptance and commitment therapy, but mindfulness is potentially a tool that can be useful to improving positive functioning in all aspects of life, regardless of whether somebody's dealing with a major form of psychopathology. One of the ways to think about mindfulness practices is that it may operate as a preventative for the development of psychopathology by reducing the effects that stress and stressful circumstances might have on our psychological well-being. So the practice of mindfulness is this idea of purposely focusing your attention on the present moment, and like ACT, accepting without judgment what's going on for you. And it's this repeated practice of mindfully being present in the moment and not being judgmental that we think lowers the likelihood that certain kinds of mental health problems are going to take root in our brains and then slowly but surely develop. So mindfulness research has shown that it has a lot of physical benefits. Being mindful through practices such as meditation or just quiet breathing, focused breathing, has been shown to relieve stress, lower blood pressure, been effective at dealing with cardiac problems. It's been effective in treating pain, and importantly, this process of relaxation improves the ability to sleep at night. So mindfulness has been shown to have a profound effect on a variety of physical symptoms, but it's also been shown to have important psychological benefits. Now, I have a link at the bottom here to perhaps one of the most important originators of mindfulness practices, both in forms of meditation and other ways, a gentleman by the name of Jon Kabat-Zinn, who's probably developed the most important approach to stress reduction through mindfulness practices. So I encourage you to watch this YouTube, and what you're going to see here is Dr. Kabat-Zinn providing a structured, guided approach to paced breathing, where you're really just reflecting on the here and now, trying to clear your mind of distracting feelings. And, it's really not designed to be a treatment, but rather it's designed to give you a feeling of, or the flavor of, what mindfulness practices might comprise. So the practices of mindfulness have been so effective that they're now being incorporated into more traditional therapies. And so we have an even newer class of psychotherapies that are called mindfulness-based cognitive therapies, and cognitive behavioral therapies. So cognitive therapy, CT, and CBT have incorporated mindfulness as an important tool in addition to some of the other aspects. And as you see here on this slide, the goal is to help individuals become more aware of their negative thoughts and behaviors, especially when these thoughts and behaviors might manifest and make them vulnerable, and to use mindfulness practices, meditation, being present in the here and now, to disengage individuals from these negative cognitive cycles, and through the practice of mindfulness and mindfulness meditation on a regular basis, to lower the likelihood that those distorted thoughts and behaviors are going to interfere with normal functioning. So a lot of, as I suggested at the outset of my discussion about mindfulness and some of these newer practices that include meditation, I think what we're going to see in the next 10 to 20 years is mindfulness-based practices becoming an important facet of all types of psychotherapies. Okay, what I want to do now for the next couple minutes is jump back by linking the Chapter 14 discussion of certain kinds of specific forms of psychopathologies with Chapter 15's focus on treatment, and just quickly run through what the science and research of psychotherapy shows us to be the best treatments for these different kinds of disorders. So I spent a bit of time talking about anxiety, and what we know to be the best treatments really depends on the type of anxiety that somebody is dealing with. So for phobias, exposure therapy, the kind that you saw in the video, is a form of CBT that has been highly effective in treating phobias, both claustrophobia, social phobias, etc. So this idea of incrementally exposing individuals to what's creating fear, and showing that an individual can manage that fear is an important approach to dealing with phobias. In terms of obsessive compulsive disorders, OCD, we've got both the talking therapies and the biological psychotropic medications like SSRIs. So these have both shown to be effective for disorders such as panic disorder. You see here therapies that are really targeting the distorted thoughts and behaviors seem to be highly effective. In general, treatments that focus on both behavior and cognition through CBT are really perhaps our most effective, especially for the long term, and I'll come back to this idea in a minute, are the most effective ways of dealing with anxiety disorders. The issue with medications is that they're very helpful, especially in the short term. But again, it's these the long-term maintenance of treatment effects, as well as the side effects that make long-term use of medicines to be more problematic. And I'll come back to this in a second. In terms of depression, again, CBT is perhaps the most effective of the treatments, especially long-term. I'm going to introduce one of the thoughts that I'm going to come back to when I summarize in a minute, and that is that long-term, one of the things we know is that talking therapies such as CBT may be more effective than psychotropic medical interventions. And in fact, it might be that medical interventions that use drugs such as serotonin inhibitors, MAOs, those may be especially important in the short term when somebody may be at their most acute and severe levels of a disturbance like depression. But that long term, really what we need are talking therapies to really alter in a fundamental way the distorted thoughts and behaviors that underlie depression. So the research has shown that CBT and therapeutic interventions that include medicines, they tend to be comparably effective, but the critical question that we want to ask when we compare talking therapies with biological interventions is what's the long-term picture look like for individuals who are using one or these other kinds of treatments. And I'll come back to that in a second. But in terms of depression, we know that CBT is highly effective and perhaps just as effective, certainly in the short term, as treating depression that serotonin inhibitors might be. So it isn't that talking therapies are always going to be the best. In fact, when we look at schizophrenia, what's become very clear, abundantly clear to us, is that pharmacotherapy is probably our best line of defense against the most difficult aspects of schizophrenia, the positive symptoms of hallucinations, delusions, etc., and especially bringing people out of actively psychotic episodes really can only be accomplished with pharmacointerventions. But what we also know to be important about schizophrenia is that long-term psychotropic pharmacological interventions alone are not going to help an individual. Given how devastating this disorder is and the way it impacts an individual in all areas of their life, we really need to start thinking of what we call combination therapies. And again, this is going to be another point that I come back to in a minute. So one of the things we know, and you can see this in terms of this relapse graph, is that long-term medicines alone are not going to guard against relapse. They might be very effective in the short term in dealing with active psychotic symptomatology, but long-term we need to combine pharmacotherapy with other kinds of treatments like social skills therapy, family therapy, or even combinations of all these. And what you see here is a graph that shows the relapse, the longer-term relapse, if you just use medication alone, if you combine medical interventions with skills training and or family therapies. There's a certain amount of relapse that comes with those, but when you follow individuals long term, in this particular study, the relapse, when you combine psychopharmacological interventions with social skills support as well as family therapy, targeting what we call the expressed emotion and the difficulties that families experience, the relapse rates tend to be close to zero. Now, long term, this might be a short term look at combo therapies and what they do, but what we know to be the case is that combination therapies have the best promise for long term outcomes. All right. Now let's look also at ADHD, a childhood disorder, and again, two principles hold here. One is that combination therapies show the best improvement over time. And in terms of long-term prognosis, it's likely to be combination therapies, those that combine medical interventions with biological interventions, such as psychostimulants with social skills and behavioral interventions that show the best long-term prognosis for children and adolescents using depression. So what you see here is some of the data that comes from the MTA study, the multimodal treatment of ADHD, which is the largest clinical trial treatment trial studying different kinds of approaches to treating ADHD. And what was found here 14 months after the end of the treatment study, that a combination of a psychostimulant with behavioral therapies, which included family therapy, peer social skills treatment for the children, that this showed the best long-term improvement. Psychostimulants alone looked pretty good too, certainly compared to behavioral treatments alone, or what we call the community as usual approach, which generally is a hodgepodge of different ways of treating ADHD. It's really this combination treatment that shows the long-term prognosis. And these data now, or the MTA study, has extended its analysis of these different approaches to treating ADHD 3 and 5 and 7 years beyond the treatment trial. And even stronger than these data, combination treatments long-term seem to be the best approach. So kind of like schizophrenia and the combination of antipsychotic medications with different kinds of psychotherapies, it's these combination approaches that probably are our best hope for treating difficult disorders in the long term. All right, so I want to summarize what I've just been talking about with some basic general principles that really derives from the research on what constitutes effective and efficacious treatments for mental health problems. And these are the thoughts that I would want to leave you with in terms of the major takeaways, the big picture takeaways from Chapter 15. One thing that I haven't talked about, but maybe becomes evident to you when you think about what I have covered, is that a lot of these different therapies, whether it's biological or talking therapy, have what we call, at their core, common factors. And one of the things that we've found through the study of different kinds of psychotherapies and biological therapies is that there are important elements that are similar across these different therapies. So, even contact with your psychiatrist, whose primary way of treating you or supporting you is through the prescription of medications, we know that there's something important about that human contact that may in fact be one of the things that enables medications to work long term. This belief that the professional you're working with has your best interest at heart and is using effectively studied tools, this belief in the human contact is an example of a common factor that is characteristic of both the prescription of medicines as well as psychotherapy such as CBT, acceptance and commitment therapy. So one of the things I'd want you to think about is, what makes a treatment effective may be the same thing that makes another treatment effective. And it may include things such as human contact or this belief that the treatment effect is going to be helpful to you. Another thing that we now know is that therapies, although they're based on a theory of what underlies or is contributing to a specific form of psychopathology, we know that psychotherapies, whether they're targeting biological mechanisms or cognitive and behavioral mechanisms, have both specific as well as non-specific effects. So treatments may lead to changes in the targeted symptoms that we're trying to address, but sometimes they often have non-intended, non-targeted biological effects, and these can be both positive and negative. So for instance, in terms of positive effects, drugs such as Ritalin, which is a psychostimulant used to treat ADHD, targets the ability of a child to pay attention, to regulate attention. But one of the side effects, or one of the positive benefits that comes along with treating attention, is that it improves an individual's ability to regulate their emotion. So this would be a positive, non-specific effect. We also have what are called the unintended consequences. So a term that you've read in the chapter and you know from earlier readings, unintended negative consequences are often called iatrogenic effects, and these are the negative effects of using a positive or a therapeutic intervention. So drug side effects is an example of an iatrogenic effect. A classic example from the psychotherapy literature of an iatrogenic effect is the use of group therapies treating adolescents who have conduct behavior problems. We find that when we put groups of teenagers who are dealing with conduct disorder, antisocial personality characteristics, when we put them into the same treatment group, the iatrogenic effect is that serves to positively reinforce these negative behaviors. So one of the other things we've learned about therapeutic interventions through research is that they often have both non-specific positive effects, but they also have negative or iatrogenic effects. A couple of final points that aren't listed on the slide, but I was just talking about in the last couple of minutes, is that we now know that certainly with more severe forms of psychopathology, long term, it's going to be combinations of therapies that are targeting both biological aspects of a disorder as well as the cognitive, social, emotional, and behavioral aspects that are going to have the best long-term prognosis. Okay, that ends Chapter 15 from the lecture point of view. Thank you very much.